Bonjour à toutes et à tous. La conférence débutera dans quelques minutes. Nous allons laisser le temps aux personnes inscrites de se connecter. Je vous rappelle que cette conférence est enregistrée dans son intégralité, y compris la période d'échange. Elle sera déposée sur le site web de l'IURDPM. La présentation durera environ 40 minutes et sera suivie d'une période de questions et d'échanges. Vous pourrez poser vos questions via la zone de clavardage. Le diaporama sera partagé à toutes les personnes inscrites et vous recevrez les instructions pour y accéder, ainsi que le formulaire d'évaluation par courriel après la conférence. Parce que notre invité est anglophone, je vais maintenant changer en anglais. So, hi everyone, the conference will begin in a few minutes. We're allowing every participant to come and join. The presentation will last about 40 minutes and will be followed by a Q&A question. So the presentation slides will be shared with all registered participants, and you will receive the instruction to download them afterwards. So now, just to introduce myself after this small introduction of the conference. So my name is Dorothy Barthélemy. I'm a full professor at the School of Rehabilitation at Université de Montréal. And I'm also the leader of the Mobility Axis at the Institut Universitaire de Recherche sur la Réadaptation des déficiences physiques de Montréal, which is also part of the CRIR. So welcome to this scientific conference. And I'm introducing now, without further ado, Dr. Sean Dukelow. Dr. Dukelow is a professor of the Department of Clinical Neuroscience at the University of Calgary and the medical director of stroke rehabilitation within the Calgary Stroke Program. He's a specialist in physical medicine and rehabilitation, and he also holds a PhD in neuroscience. He serves as director of research of the Physical Medicine and Rehabilitation Residency Program. He has a great research, which you will hear a little bit there. He's the director of CanStroke, which also is a big part of this conference, but he has his own research, and maybe a couple of things that he focuses on is developing robotic assessment tools to accurately measure sensory and motor functions, as well as cognitive functions. He explore brain functions and post-stroke neuroplasticity using robotics and neuroimaging techniques, and he used non-invasive brain stimulation to support sensory, motor, and language recovery after stroke. So he has really a breadth of great expertise. And today he's going to talk to us about CanStroke Recovery Trials and the building a national stroke recovery trials platform. Thank you very much, Sean, for coming.
Merci. Thank you very much for the invitation to present. I'm going to talk in English. I have un peu français, mais n'est pas très bien. So we'll see how we go. And if you have to ask me in French, lentement, s'il vous plaît. Okay. I'm going to talk about CanStroke Recovery Trials. I have a number of disclosures. A lot of these are because of my role in leading the network. And we work with independent investigators looking to run studies, but also with industry. And so that shows up when I show my disclosures. I'm going to talk three parts to the talk. One, just about the CanStroke Recovery Trials platform to give everyone in the room an idea of what it is and what its heritage is, essentially. And then two trials, one that's ongoing and one that's up and coming, both of which you might be interested if you're able to participate as a site. So where did CanStroke actually come from? Well, its origin started in Ontario back in 2003. And at that time, the Heart and Stroke Foundation had separate boards for each province. And Heart and Stroke Foundation of Ontario funded an initiative which was called the Heart and Stroke Foundation Center for Stroke Recovery, which it ran from 2003 to 2012. And it was Ontario-centric, to say the least. It had sites at Baycrest, Sunnybrook, and University of Ottawa, and much of it was focused on preclinical research with a little bit of clinical research that was going on. They did functional MRI, magnetic encephalography, and cognitive issues. But that's really where we got started as a stroke recovery community, trying to work across multiple different centers in the country. And in 2012, Heart and Stroke Foundation made a change, and they essentially got rid of the provincial boards and became a national organization. And when they did that, they didn't really initially know what to do with this Ontario Center for Stroke Recovery that they had. And so what was created was something called the Canadian Partnership for Stroke Recovery, which I'm sure there's people in the room that are pretty well aware of that organization. And what happened with that organization was that the Heart and Stroke Foundation would give $2 million a year that got distributed to sites that were putting about $400,000 a year in matching funds in, and they got their matching funds back. It was kind of an interesting way of doing things. But what you can see on my slide here are the different centers that were involved. And so the scope of geographic scope of the Canadian Partnership for Stroke Recovery expanded. And that group did things like it gave small grants, $50,000 for pilot funding to get a trial up and running or get a study up and running, included preclinical work and clinical work. And it also had small grants that were used for studentships, so graduate studentships and things like that. It did a lot to advocate for stroke rehabilitation in the country. And so in about 2022, Heart and Stroke Foundation came and said, look, guys, this is over. We're no longer going to fund this. And so in 2023, the Canadian Partnership for Stroke Recovery came to its end. And so as a national group, we were forced to figure out what we were going to do with our lives, kind of like a teenager, what's going to come next. And so these are some of the things that the partnership did in terms of research, educational modules that were developed. Some of your staff may have been trained with some of those education modules. And in their later years, they gave out some money to allow matching with Brain Canada, which is a Health Canada funded granting agency for brain health, which allowed us to have an initial CanStroke that Mark Bailey and Janice Eng led in 2016, and now CanStroke 2, which is what I've led in 2023 after the CPSR sunset. So I think I have a nice western sunset coming from Calgary. Oh, this looks a little more like Utah than anything, but so CPSR sailed off into the sunset, and we started with CanStroke. And so now we've gone from funding from the Heart and Stroke Foundation to grant funding that we have to apply for every 3 years from Brain Canada. And we were able to secure about $3.5 million from Brain Canada, almost. 50% of that comes from Brain Canada. What we had to do is fundraise in our institutions. So we had some money from Canadian Partnership for Stroke Recovery, and I managed to convince the University of Calgary to put in a bunch of money, and Sunnybrook. And the purpose of that was strictly a clinical trials platform. And the only reason for that is because it was what we thought we could sell at the time to the funding agency to continue to support things. And I'll tell you what we do with CanStroke in my next few slides. But at the time, we had 7 centers that were working together on trials. And we proposed that we would expand. And you can see the location of the sites here. And we started to expand to other centers that you might not have traditionally thought of as being heavily involved in stroke recovery research, but it turned out we're interested in participating, like Kelowna and Windsor, Quebec cities had a lot of stroke recovery research going on there, or Charlottetown. And so we expanded out, and the reviewers liked that we were expanding because it increased access to people from different parts of the country, from different walks of life. So what was the pitch at the time? Well, 25 randomized control trials that have been done since 1970 for the upper limb and the lower limb. And only a small number of them have actually changed practice. If you're a frontline clinician and you're listening or you're watching, you can think about which trial may have caused you to change practice. But it's usually because they're a single center study. They've got a small sample. And oftentimes, unfortunately, we go to replicate them at a different center and we can't replicate them. And we've made that, we've had that challenge literally hundreds of times with what we've done. And so we argued that if we were able to get a larger platform, we could run larger trials. We could make sure that what happens in Montreal is the same in Toronto, Calgary, Vancouver, Charlottetown, Windsor, and that our frontline staff actually learn the new treatments that we're doing so that they can roll them over more easily clinically. So we can move through trials more quickly, and then we can also reduce some of the administrative burden of getting a clinical trial up. For those of you who run trials, you'll recognize that it's a lot of work to actually get a trial going, particularly if it's a Health Canada regulated trial. So the other thing that we wanted to do is have sort of a common set of outcome measures. So we have clinicians across the country who, if we say we want to do a trial on X, know that the outcome measures associated with that are Y and Z, and they can easily do those outcome measures. So, and lastly, we realized that we're sort of the new frontier. Acute stroke has had its day. It works. The treatments they have work in about 12 to 20% of patients. And as rehab people, we're left with everyone else. And those people deserve more than they get right now. And so in order to do that, we need to collaborate and foster the development of our junior colleagues, because they're the future of research, the future of the clinical work. And so that's why we went in and we developed CanStroke. This is the least exciting slide I'll present today, I think. It just shows the governance model. And so we have a steering committee, an executive committee, and a management team. And I understand that Farrell, who's our platform director, was here yesterday with the SPIN course, our stroke program and neuro recovery, which we do for the trainees. So they get to see what it's like here at the hospital. And some of them may work with rodent models of stroke, and some of them may be clinicians or clinician scientists from other parts of the country. And that experience of coming into a hospital or a lab or a clinical setting from another site works very well, because people get to see what it's like to be in another part of the country, learn new things. And we often see a lot of migration between centers, and that makes us richer because of that. So currently we have a whole bunch of pins on the map that Farrell's put on for me. And these are sites that have been involved in CanStroke trials over the last 3 years. The most recent trial that we finished was a trial called Walk and Watch. And I don't think I'm supposed to say where it was accepted, but accepted at a very good journal with about 306 patients in it or so. So, and Janice Singh was the senior author on it. Sue Peters was the lead author. And so our group is large. We have 64 primary investigators, 86 research coordinators, 176 trainees involved, and we have 3 stroke community advisors. So those are patient partners, people with lived experience, lots of different things that they get called. And then we have a number of different folks across the country who are affiliated. And many of those are preclinical researchers that work with us or come in and come out of trials that we have going on. So it's a pretty big group. These are trials that we currently have going on or are about to go on. There will be a quiz after this. I'm kidding. They range from a drug trial, Camaros, which I'll talk about, to seated exercise trial here, to virtual exercise, a robotics trial. This is a virtual cognitive behavioral therapy trial, another drug trial. This involves some robots. This involves brain-computer interfaces. So they range from inpatient stroke trials to outpatient stroke trials to folks with chronic stroke. And essentially what happens is, if you're an investigator, you come to us and say, hey, I've got an idea for a trial. We try to support you with that in terms of getting a grant ready, figure out which sites would be good for you to be able to run that trial so you can access it. If you are a site, when people come through with those ideas, we ask you if you want to participate in them, if you think they'd be good, and if they're a fit for your site. So if industry comes through, we do the same thing. We ask, is this a trial that you'd be interested in taking part of? So because certain trials fit the population that you serve better than others. And so we try to, it'd be lovely if every site could run every trial, but that's not going to happen. And we recognize that. And as we add more sites, we figure out what fits best, right? So, okay, that's about CanStroke. I guess we'll do questions at the end. Is that okay? Okay, I got 2 more parts to my talk. One is about a trial called Camaros. The other is about a trial called Modex. And so it would be really nice if the site here decided they wanted to be part of either of these trials or both of these trials. But I'll tell you about them and I'll try to get you excited about them, and then we can see if we might make that happen. So Camaros is a Health Canada regulated, double-blind, randomized, placebo-controlled trial looking at a medication called Maraviroc. And I'll explain why in a second. So currently, my slide is out of date as I'm looking at it. We have 35 patients recruited to date. We're aiming to recruit 120 patients. We have 10 sites that are up and running. We have potentially 6 more sites that could be up in the next 2 to 3 months. And this is a drug that is expected to improve motor learning and motor recovery after stroke for both the upper and the lower extremity. And so we have done something that you don't see very often anymore, which is dual primary outcomes. So for the upper extremity, the primary outcome is the Fugl-Meyer test, which is a pretty standard upper extremity outcome measure you see and use mostly in research. We probably should be using it clinically so we can tell if our clinical outcomes match with our research outcomes. And then for the lower extremity, the 10-meter walk test. Secondary outcomes, action research arm test, and 6-minute walk test. And the hypothesis of the study is probably not that surprising. We think if we give you the drug rather than the placebo, you're going to do better on these. So I'll tell you a little bit more about the study. Okay, so why Maraviroc? It's interesting, you know, we don't have a lot of drugs that improve motor recovery. In fact, we really don't have any. We have drugs to treat spasticity. We have drugs that can improve people's mood. And we recently had a failed drug trial in Europe of Sinemet, which gets used in Parkinson's patients, so a 600 patient study, and it showed no effect in patients who were with subacute stroke to improve the recovery. So currently, I think this may be the only drug trial that's going on for drugs to improve motor recovery in stroke. So it is also being used to try to improve dementia. And it's because of its putative role in learning. And so Maraviroc blocks a calcium chemokine 5 receptor, or CCR5. And if you work in the preclinical side of things or want to read the evidence, probably something that summarizes most of the evidence, I've put this paper here, which is a cell paper from Tom Carmichael's lab, where they did a number of different experiments in animals, in rodents, looking at the impact of blocking the CCR5 receptor or raising animals that don't have a CCR5 receptor, and how much better those animals actually learn if they give them a stroke and how much better they recover. So I'll show a plot on my next slide. So this is from the paper I just showed on the last slide. And they do behavioral tasks in rodents. So grid walking tasks, sort of a task of dexterity, I think, for the rodents. If you don't walk on the grid very well, you kind of fall on your belly. It's probably not a good thing. And the cylinder task, they move around and get up and touch the cylinder. These are sort of common tasks that get used preclinically, common behavioral tasks. And what Tom's group did is they caused the animals to have a stroke. Then they followed them out to 9 weeks. And within 3 days after they had the stroke, they started the drug Maraviroc that blocks that CCR5 receptor. And what they're showing here is if you give the drug, you end up with a significant improvement in the orange line compared to if you don't give the drug. And that happens whether you give the drug at 3 days post-stroke for the rodent or 3 weeks post-stroke for the rodent. So this is one line of evidence that we considered nationally when we developed the Camaros trial, that regardless of whether you give the animals the drug or you create a knockout that takes out the CCR5 receptor, you see this similar pattern. They recover better. So it seems to work in mice. That's a good start, but not all drugs that work in mice necessarily work in humans, and we know that from neuroprotectants over the years. What about in humans? Well, there's an observational study that comes out of Israel named the Tabasco trial. And a rare gene mutation in humans makes people not have the CCR5 receptor. That CCR5 receptor is throughout the whole body. It's very ubiquitous in the brain. But what this group did is it followed these individuals who are born without CCR5 receptors and watched them when they had a stroke or a brain injury. And it turns out if you compare individuals that have the CCR5 receptor versus don't have the CCR5 receptor, which again is a very small percentage of the population, they end up walking better after they have a stroke. Their speed's higher. They have higher balance scores. They score higher on the mobility domain of the stroke impact scale. And when they look at the genetics of things, if they're homozygous for not having the CCR5 receptor versus being wild type, they actually have higher Berg balance scores. So in a way, it's almost protective, neuroprotective to not have these CCR5 receptors. But I got news for you. If we think about our whole audience here, unless you have Ashkenazi Jewish heritage, your odds of having a CCR5 receptor are extremely high. And so we may need that drug or something to block CCR5 someday. So this is a summary of probably the last 15 years of research into CCR5 receptors. And there's still more that we need to know about how it relates to stroke. But if you knock CCR5 down, you get better motor recovery. So it promotes knocking it down or blocking it, promotes bilateral connectivity in your premotor cortex, prevents dendritic spine loss after a stroke. And so we went forward with these two lines of evidence to say that, Maraviroc might actually enhance learning and memory with individuals after they have a stroke. So theoretically, this could be the drug that improves recovery that all of our patients have wanted for many, many years. So let's move on here a little bit. This slide is probably going to be difficult for anyone like me whose eyes are waning and we're getting a little older and you're looking at this on your laptop. So I apologize. Time to pull out the bifocals or the reading glasses. This is how our trial's working. So individuals have a stroke and we're recruiting them between 5 days and 8 weeks post-stroke. And we've set that up because we're looking for inpatients who have hemiplegia to try this drug. They take the drug twice a day, 300 milligrams, and they'll take it just for 8 weeks. We do an assessment when we recruit them. We do another assessment at 4 weeks, at 8 weeks, and 6 months. And 6 months is our primary endpoint. So I've already told you what the primary outcomes are and the secondary outcomes, but we have a few sub-studies that are going on. At the front end, we have a study going on called Order, and that's just getting up and running. And we're running this study. It's Ada Tang, who's at McMaster, AJ Quigley, who's at Halifax, are running this study on the platform because we, in Canada and worldwide really, recruit about 60 to 63% males and about 37 to 40% females into studies. There's a lot of reasons why that may be, and we can talk about that in the question period. So, but what we're trying to do is create materials that allow us to recruit more women into trials so that women have equitable access into stroke recovery trials. And so that's the Order study, which actually starts somewhere in here on the diagram. So when people come for their first assessment, they go through a battery of assessments. It takes about 60 to 90 minutes. And then they do a few other sub-studies. So one is wearing activity sensors. So Courtney Pollock is responsible for this. She's at UBC. And the patients, I think I've got a slide a little bit later, but the patients wear sensors on their wrists and ankles for 7 days straight. And when Courtney told me she wanted to do this, I thought there is no way I'm going to get patients to do this for 7 days straight. And it turns out that the vast majority of them will wear the sensors for 7 days straight. So I was wrong. And Courtney was right. And so, and then we have another study looking at motor learning. And I'll talk about that a little as I get further forward. So what do the patients do? Well, when they're inpatients, they do standard inpatient rehab, whatever goes on at your center. And our sponsor asked that they do an extra 60 minutes of GRASP, the graded repetitive arm supplementary program, at some point during the day. It could be after hours, could be before they start their therapy. And then when they get discharged, which could be any time in that 8-week period that they're on drug, they go home. And if they're able to walk, we ask that they walk for half an hour a day. And if they're unable to walk, we have a seated exercise program that was created by Michelle Plowman, Marilyn McKay Lyons, and Janice Singh that the patients would do for 30 minutes. And we ask that they do 30 minutes of grasp. And they do that until they stop taking the drug. And then they're on their own. They do whatever outpatient therapy is going on or not. And we see them back at 6 months. So who are we taking into the trial? I would bet that upstairs you have a few people that meet these criteria. Just saying. Okay. Primary ischemic anterior circulation stroke. So those are middle cerebral artery and anterior cerebral artery strokes. They have to be adults. I've already talked about the time window, 5 days post-stroke, but 8 weeks, within 8 weeks of their stroke, and then hemiparesis. So we're excluding patients who were previously disabled before their stroke. Because the drug is metabolized in the liver, we exclude patients who have hepatitis. And I don't know what it's like in Montreal, but what I found is that many places in the country, our acute stroke doctors are not checking liver enzymes or renal function tests before starting patients on a litany of medications. And so we've picked up 2 cases of hepatitis. One was hepatitis C in our screening for the trial. So it's been interesting for me. So you essentially excrete the metabolites in the liver. So we need people to have not be in renal failure. And then there are some medications that are processed on the cytochrome 3A4 in the liver, which are could potentially modify what the Maraviroc does. And so number 4 and number 5 here are excluding patients who are on those medications. And with respect to anticonvulsants, these are ones that we don't use very much anymore, not in the last 5 or 10 years. Some patients are still on them. And then you've got a list of antifungals. Again, there's not a high level of usage in most of the patients that I would see. So that gives you a bit of a snapshot of who we take in. So I mentioned that people do grasp. Can I ask how many people in the audience are aware of what grasp is? We got just pretty much almost everybody. Okay. So for the 2 of you who aren't aware of grasp in the audience, Janice Singh's got a great website with videos, and it's been translated into multiple different languages. And it was originally developed as a tool to take home so that patients could do this when they take home to work on their upper extremity. But she has studies where they have done it in hospital, which is why we're using it in hospital. It's very well controlled. You can set it at different levels depending on the level of the patient. So if you're one of the few people who hasn't heard of it, go to the website and you'll learn more about it. Okay. I mentioned about Courtney Pollock and wearable sensors. So we're using these little activity sensors. They're about that big. So, about the size of an Oreo cookie, essentially. And then we have little bands that the patients will wear on their wrist or on their ankle. And essentially they can take them off when they shower, but they wear them. And we will have a little ton of data coming in. And we're working with Waterloo University, Bill McElroy, because he's got a number of studies within the community looking at activity, looking at sleep with the sensors. And so we'll see what we turn up. But at the end of this, we'll know what a lot of these patients who are inpatients are actually doing when they're not in the rehab gym, which might be a little scary for those of us who are working clinically in the room, because I'm a little afraid that some of them aren't doing very much at all. And we'll find that out. Okay. And then the other sub-study I'll talk about, we have 2 motor learning tasks we have the patients do. And this has been something that's been a real learning experience for me. So Laura Boyd, many of you may know at UBC, has done a bunch of work in motor sequence learning, which is not what I'm showing here. Motor sequence learning is a bit like that game Memory that you may have played, where you turn over a card and it's an apple, and you turn on another card and it's an orange, and you're trying to find the apple to match to the apple and the orange to match to the orange, right? And so you learn this sequence that you go through. And so we have a motor sequence task that's like that. I will tell you that within the first couple of weeks post-stroke, people have extreme difficulty, get frustrated, and we've now had to create an off-ramp so they can stop doing the task. And just so you know, everything we know about motor learning and stroke comes from that task. That's the task that's most commonly been used in chronic stroke. We don't have a lot that we know about motor learning in subacute stroke, where we actually deliver most of the therapy that helps the patients get better. We rely on our assumptions about that task, which we're finding doesn't actually work in subacute stroke. So that's not published yet. We've got to get through the trial and get more people through, but it's been interesting to watch in the frustration of some of the research, some of the initial patients we had through and research coordinators when we couldn't let them just say, we can't go on and do the motor sequence task. We have another task, which is developed by Tyler Clough, who's at Calgary with me. And it's a visual motor adaptation task. And the patients seem to take to that a little better earlier on after their stroke. And essentially, this is a timeline for what happens. They're either on a tablet or on a laptop or using a mouse, or on a desktop using a mouse, and they make a reaching movement from point A to point B. And what we can do, it's a miracle of modern software, is when they move from A to B, we can actually shift the cursor so the cursor moves in the opposite direction. I've had computers that have done that are broken for many years now, but Tyler's managed to actually do this on purpose. And so what happens if you move the cursor to one direction, and this is what these plots are showing, is that eventually the person starts to reach out here so the cursor goes where it's supposed to, which is the point where they're going. That's the purpose of adaptation. In real life, not when we're on a computer, we do that when we're out throwing a baseball or playing golf and we're trying to compensate for the fact that there's wind, right? Or anyone who's done their hair or shaved in a mirror recently, you have to make a visual motor transformation to be able to do that. And so this is looking at some of the same circuits in the brain that are responsible for that. And what we've found, and this is from a paper, we did this in a robot called a kin arm for this particular paper that I've taken the plots out of. But we find that many of these individuals are actually quite impaired when they go to do this. So the people who were trying to use therapy to improve, relying on the fact that they can learn, we're finding out when we actually do assays of learning that they have learning impairments. Wrap your head around that for a minute. It may explain why some of our patients actually don't improve as much as we think they should, because they're motor learning impaired. So this is why the sponsor came to us and asked us, they said, you're giving a drug that should improve motor learning, test motor learning. So we've got this as a sub-study. There's a third sub-study, which we just collect people's neuroimaging. So their CTs and their MRI scans, and we will look at how where the lesion is matters to what the recovery looks like. But I think at this point, I've summed up most of Camaro's. We're going to continue until we complete the trial. I've already mentioned we've got 10 sites recruited, and that was my sales pitch. So you guys can think about whether you want to be part of the trial, because I'd love to have you in it. I know it's not the easiest thing to do. I'm going to move on, and the last part of my talk is talking about a trial that Mark Bailey's running from Toronto Rehab. And so Mark recently got funded from Canadian Institute of Health Research, CIHR, to look at post-stroke fatigue with a trial called MODEX. So Mark sent me his slides. We're going to see how this goes. Okay. So Mark had very few pictures on his slides, so I added a few. So not necessarily approved by Mark. So what's post-stroke fatigue? How many people in the room have dealt with a patient who has significant post-stroke fatigue? So I have a patient who I talked to yesterday, actually, and he's a dentist, and he was, in fact, probably had the busiest practice in Calgary, and then had a stroke. And after his stroke, we were lucky to get him back to work 2 hours, 2 days a week, because he was so fatigued. And that's continued for a number of years now. And so it is a huge problem. The population in Calgary has changed. I've been out there since 2008, and the population has changed dramatically. I am often the oldest person in my clinic, and that makes me feel very old. because I'll see lots of people in their 30s and their early 40s that come through who've had a stroke. Where there's a huge amount of immigration in Calgary. And it's often those individuals in my clinic, at least, that complain of fatigue, and we can't get them back to work. Some of them are moms, and they're trying to look after kids, and it's a real problem. And so, in terms of what's going on out there, well, let's talk about what's going on. So there's this debate, central fatigue versus peripheral fatigue. And if you don't say which one in certain audiences, you can get yourself into some trouble. But so central fatigue is this idea that people are tired because of the stroke itself, right? And it's something about changes to blood flow, and you get physical and psychological symptoms. So, and then there's this peripheral fatigue, and that is, you just can't do as many reps as you used to be able to do, is kind of one of the way I think about it. So you don't actually have the same physical functioning that you had, or neuromuscular functioning that you had before. Now, if you do that for long enough, you get disuse, you lose muscle strength, and it's just kind of a spiral down with fatigue. And the patients it's very challenging to encourage someone who's completely fatigued to go out and get exercise and do resistance training and try to get back to work. So Mark likes diagrams that are even more complicated than mine. So I think this is straight out of the grant that got this project funded, but it was different factors. So pre-stroke, and you can see some of the demographic factors there. So if you were fatigued before your stroke and depressed, I got bad news for you. It's not going to get better with the stroke usually. So you can have peripheral factors like what's your physical function or what your cardiorespiratory function is like. You can have sleep disturbance. Something that's common actually is sleep apnea, obstructive sleep apnea. So I got asked to talk to someone. It was the head of the Brain Institute in Calgary had called me, and we had somebody who was important, and they asked me to talk to them. And they'd shopped around for their medical care around North America. And I started talking to them, and I went, okay, he's describing this fatigue. And then I talked to his wife, and he's a huge snorer, right? Stops breathing at night. I said, you've probably got obstructive sleep apnea. You need to get tested. So they went and got the test done, or they went and got the overnight oximetry done. So it just tests whether your oxygen level dips essentially with a little machine. It's not very expensive, and it's easier to get than the traditional test where you come into a lab and get tested. And sure enough, he's got horrible sleep apnea. And his wife said, should we get the test repeated? And I said, no, like you don't even need to go to a sleep lab. You need CPAP to be treated. And so people do not recognize quite commonly how bad their obstructive sleep apnea is. And so in this study, Mark's got a little device that's actually should be picking off whether the patients have sleep apnea. So you can have people that come in with insomnia as well. Often the patients I see have daytime sleepiness. And then there's psychosocial factors, which play a role in a lot of the patients that we see. And then where did the stroke actually happen? Are there cognitive issues? Is there pain? And am I not doing a good job giving my patients something that's sedating, that's actually making things even worse, right? So all those factors can play a role in post-stroke fatigue. And so there are two things we think we know that can improve post-stroke fatigue: aerobic exercise and a drug called modafinil. And the evidence for the drug called modafinil comes from a couple very small, like 30 or 40 patient studies. And so there is a study going on in Australia now called MIDAS, which will be a larger 250 or 30 patient study, just looking at modafinil. Our group, Mark, wanted to look at the combination of modafinil and exercise. And so the hypothesis is that if you have aerobic exercise and modafinil, you should get better. And then he's got secondary hypotheses around quality of life, fitness, mood. And they're as you'd expect. If you participate in the treatment, you should get better. So it's a phase 3 study. And I think somewhere on here, he's got how many patients we're actually recruiting, but it's modafinil at 200 milligrams. And it's a tele-rehab structured exercise program 3 times a week for 8 weeks. It's based on FAME, which is another one of Janice Singh's programs, more for the lower extremity. So it's a fitness and mobility exercise. And there's 2 groups, the placebo and exercise and modafinil and exercise. And I think if I flick to my next slide, gives us a little bit more information. So there'll be some testing and sleep apnea screening before the patients get randomized, because that's such a big factor in what goes on. They have to be adults, more than 3 months post-stroke, which is it's typically when I've seen patients in clinic that are complaining about this. They're having trouble going back to work or having trouble looking after the kids. And they think it should be getting better, and they're right. It should be getting better at that point. So they have to have a stroke. And then the outcome measure for this is this multidimensional fatigue inventory. So they have to score high enough on it to prove that they have fatigue. And then they have to be able to participate in moderate exercise, and they can't have been severely disabled. And he's excluding patients who have contraindications to modafinil or who are on stimulant medications, those with subarachnoid hemorrhage, those who have impaired comprehension, and those with severe motor impairment or who couldn't participate in exercise. So, or who have musculoskeletal injuries that can't participate in exercise. And the outcomes are aligned with that Australian trial, the Midas 2 trial, so that in the end, they can put the data together from both, and you'll be able to see how much does modafinil get you versus how much does modafinil plus exercise get you versus how much does just exercise get you in terms of treatment. And so it's this multidimensional fatigue inventory, 56 days after they've started the exercise and the drug. And so it's a 20-item questionnaire. I don't think I'd heard of it until I actually read the Midas trial. So if you haven't heard of it, don't worry, you can go look it up. But it's got 5 different fatigue domains, and then they're scored 1 to 5, and they end up with a sum total of 100. Okay. I'm really happy that Mark sent me this slide because I'm sure that everyone can actually read it. I apologize. I lost my luggage coming here and had to go to buy some clothes this morning, so didn't have a chance to adjust Mark's this particular slide. He's got essentially these are all the different outcome measures which I'm sure can't see even if you're at home on a computer, but he's got central quality of life, fatigue severity scores, some health economics questions, and then there's some physical things like 5-meter walk, pain, central things like a little bit of looking at cognition with the MOCA, depression with the depression anxiety stress score, and then trails, neuroimaging, modified Rankin, and then he's going to do the Epworth sleepiness score, as well as this patch that I mentioned that patients will stick on and they wear to see what their apnea hypopnea index, so measure of sleep apnea is. So, and then also some psychosocial measures. So looking at locus of control and the impact on caregivers and caregiver burden. And there's demographics, but it runs off the bottom of my slide, so I'll stop there. And gives you an idea of what's measured. So probably the important thing is these are patients who are probably going to be in an outpatient environment, might be coming back to be seen, and probably tired, falling asleep in your waiting room. So I'll sum up. Hopefully I've done okay on time. I started by talking about CanStroke. And so CanStroke is a trials platform that's inclusive. We'd love it if you guys would entertain joining us going forward. Camaros is looking for more sites. We would also love it if you join us on that. And then Modex is getting up and running. It's in ethics in Toronto, it's in ethics in Calgary, and Mark is looking for more sites for that. And there are a lot of patients who have hemiparesis and fatigue, but we've got a lot more trials going on than just these 2. So we'd love for you guys to be a part of it, and I'm happy to take questions. Again, en français, lentement,